Good morning, everyone. Thank you for joining us this morning. Stacy, would you like to begin?
Okay. I think I was speaking with my mute on. Can you hear me now?
We can.
We can hear
Great.
you.
Yes, so welcome and thank you everyone for joining our webinar today. So today we're going to be looking at results specific to the state of Colorado on how cost and quality outcomes differ among Bridges to Excellence recognized providers, so that's the BTE, and non-recognized providers. And we're going to have three presenters today, myself, Stacy Eccleston, and Marcela Reyes. Both of us are with the Center for Value in Healthcare at Altarum. And Bob Smith, who I'm sure many of you know with the Colorado Business Group on Health. For logistics, if you have questions as we're going through the presentation, feel free to type them into the question and answer box, and we'll take a look at them. We'll pause throughout and address some of those questions. I think we have a small enough group that at the end we can open up the phone lines so that you can, so that we can hear you and you can ask questions then as well. So specifically, Marcela, who is the BTE program manager, will give us a little background on the BTE programs, its history and basic components. I will then give you an overview of the overall study questions and a summary of the findings with respect to those questions. And then we can talk about the study methods as well as limitations, and then we'll take a deeper dive into the results of the study. Bob Smith from Colorado Business Group on Health will then talk about some other earlier findings with respect to the diabetes program in particular and the potential impact that that program can have on improving the quality of care and the outcomes for diabetic patients, and with those improved outcomes then leading to a significant return on investment for any sponsoring employer or health plan. So Marcela, if you want to get us started with a little background on Bridges to Excellence.
Yes, of course. Thank you, Stacy. So Bridges to Excellence, as you could see here on the timeline on the top half of this slide, has been around for a while now. It was founded in 2002, and the BTE programs recognize clinicians who deliver excellent and superior patient care. The BTE programs do measure the quality of care delivered in provider practices, so this would be an ambulatory program, right? And we also place emphasis on managing patients with chronic care conditions and who are or would be at most risk of incurring potentially avoidable complications. All BTE recognitions cover chronic care conditions in order to promote comprehensive care delivery and strong relationships between patients and their care teams. Providers who meet the BTE performance benchmarks are recognized in a number of payer websites as well as private sector transparency tools. Like I mentioned, you could see in this timeline that the BTE program was initiated early on, and we did work very closely with NCQA at that point, where we developed the diabetes and cardiac care recognitions, which they still have that, but we moved on throughout the years and included other chronic care conditions. So we continue to add those as we move along throughout the years. So the Bridges to Excellence programs, so eligible clinicians and practices voluntarily apply for this recognition via a submission that they would provide to us, all clinical data, of course, and so they have different methods of being able to provide this and submit this to us. It could either be via their EHR, via NCQA, which we do honor their programs, and then of course via our newly launched web portal. All recognitions are based on clinical evidence. We assess how well clinicians perform on patient assessment, reassessment, via, of course, such things as testing, screenings, on-site visits, and so on, patient education, shared decision-making. And then, of course, measures include process and outcome measures, such as blood pressure measurements, blood pressure control, hemoglobin A1C, how many times are they being taken, and of course, how well are they improving those lab values. And they're generally endorsed by specialty organizations. BT recognitions the amount of recognitions that we have right now are a total of 8. We are working on our 9th. So the current active recognitions are asthma, cardiac care, chronic obstructive pulmonary disease care, depression, diabetes, heart failure, hypertension, and inflammatory bowel disease. Providers are recognized at various levels depending on how their scores compare to their peers. And as I mentioned, we are working on that 9th, which at this point is the maternity care program. Stacy?
Great, thank you, Marcela. So for this study, our research question was pretty narrow. The question is, for an individual patient of a BTE recognized provider versus the patient of a non-BTE recognized provider, what is the effect on episode-specific costs and episode-specific quality? And we'll talk more about what an episode is, but basically it's the treatment that's provided to care for a patient over the period of 1 year, in this case, for a specific condition. And in this case, we're looking at 3 conditions: coronary artery disease, diabetes, and hypertension. So the recognitions in those 3 categories. For the quality measure, that is the likelihood of experiencing a potentially avoidable complication, or we refer to them as PACs, and we'll talk more about those PACs as well. So and the answer to that question is, all things being equal, patient episodes at BTE recognized providers actually experience 11 to 25% lower average costs for each of those 3 conditions, and approximately have a 5% lower probability of experiencing a PAC. For diabetes and hypertension, there was no real difference on that measure for coronary artery disease. Now, one caveat here, while we attempt to isolate the effect of the BTE recognition as much as possible through the methods that we'll talk about, there certainly may be other factors not accounted for that could explain the results in part. So this is not necessarily a cause and effect analysis, but rather a correlation. So about the methods, we're analyzing data from the state of Colorado using the APCD for commercial claims spanning 2015 through 2016. That data set includes commercially insured individuals less than the age of 65 identified as having one of those 3 episodes associated with one of the BTE recognition programs in Colorado. So coronary artery disease, or CAD, diabetes, and hypertension. And these patient episodes are identified using the Prometheus episode grouper analytics, and we can talk more about that. There are some exclusions. We exclude patients that have a coverage gap during their episode, a gap of greater than 30 days. This means we might be missing claims for that member, although this comes less into play for an APCD where you have multiple payers. We also exclude members that have any Medicaid or Medicare coverage in 2016, and we're including only residents of Colorado. So although treatment may have occurred in Colorado, it may be for a resident of another state. There were no exclusions based on the providers that were attributed to these patients. The attribution of a patient to a particular provider is based on the volume of visits or treatment for that particular condition. So the highest volume treating provider is the one that owns that patient episode. And any provider that was recognized in 2015 was considered to be in the BTE recognized provider group. And note that there's substantial overlap in the recognitions, particularly among the coronary artery disease and the hypertension categories. I should note here that if you have any technical questions regarding the techniques that have been applied, I do have a colleague on the phone, Matt Daly, our resident statistician, who can help answer those questions. But here's sort of the layman's description. There were 2 separate models run, one for the cost and one for the quality, or the PAC rates. The cost model was Windsorized at the 95th percentile. This just means that outliers that were above the 95th percentile of cost were set at the 95th percentile. And then there was a log transformation of the data for a better model fit so that residuals were more normally distributed on either end. The PAC outcome, the potentially avoidable complications outcome, or the dependent variable there, was the probability of having at least one complication. And for both the cost and the complications, we're talking about in 2016. Those complications were based on the Prometheus episode definitions, and I'll tell you more about that in just a second. And we control for things, so there's kind of a built-in severity adjustment. So we control for things that might impact those outcomes, such as the age of the patient, the gender to the extent that that might affect the costs or the complications, any pre-existing or co-occurring comorbidities or conditions, the type of insurance, whether it's PPO versus HMO, the presence of behavioral health conditions or substance use disorders that can really have an impact on the outcomes, the zip code of the residence of the patient, as well as episode-specific risk factors and subtypes, like if we're talking about a type 1 versus a type 2 diabetes. The analysis assumes the effect of the control variables is the same among the two groups, and both models for the cost and the complications include all of those control variables. For the episode costs, the measure is the percent of difference in average episode costs, so that's the amount paid to treat the patient over a one-year period. So the percent difference in that cost between the BTE recognized providers and the non-recognized providers. Again, holding those control variables or covariance constant. And for the complication measure, it's the difference in the probability of experiencing a complication between the BTE recognized providers and then the non-BTE recognized providers. So that was sort of about the model. So what are these Prometheus episodes of care? And in this case, we're talking about 3 chronic conditions: diabetes, hypertension, and CAD. So the episodes are patient-centered episodes for the treatment of an illness or a condition that are severity adjusted to the patient's comorbidities. So they include all the covered services related to that care. They were developed over time, really since about 2006, with the help of clinical experts. So specialists determined which services, as indicated by the procedure codes and or the diagnosis codes on the claims, so which of those should be considered to be part of the episode. They're generally time-delimited, so in the case of procedures, generally they include a short period that leads up to the surgery and then a period post-discharge, typically it's 90 days, to cover all of the follow-up services and potentially any readmissions or complications. For the chronic conditions we're talking about, they're really triggered by a relevant diagnosis code and then confirmed with subsequent claims that we find. Those are ongoing, but the costs and the complications for those chronic care episodes are measured on an annualized basis. And in this case, the cost and the complications we're talking about are during 2016. Those definitions created by the clinical expertise also group claims into categories of what we consider to be typical care versus the complication. We'll go into that a little bit more in a moment. And as mentioned, the patients are attributed to the specialist or the primary care physician who had the highest volume of visits to treat the condition, as indicated by the diagnosis codes that are on the claims. So what are those complications or potentially avoidable complications, or PACs? We think of them as potentially avoidable complications, costs, and or care depending on the audience, because they really manifest in all 3 of those Cs. Basically, it's any event that negatively impacts the patient and is potentially controllable by the physicians and the hospitals that may be co-managing that patient. And we stress the potentially here because we recognize that these are not absolutely controllable, but rather they're potentially controllable. So the power really is in the relativity of these PACs across providers and across episodes rather than the absolute level. Simply because the methods are consistent across the providers that might be being compared. It's basically a metric of potential waste within the healthcare system that could be turned into potential savings, or at least be used to inform process redesign. Any potential savings from reducing these negative events can, be divvied up to providers perhaps as a bonus for having relatively better outcomes, to payers in the form of decreased outlays, and certainly to patients as better health outcomes and, again, lower costs. The way that the PACs are identified is through the diagnosis codes on the claims as they're being assigned to an open episode, in both ICD-9 and ICD-10 diagnosis codes. They might also be potentially identified by the type of claim. A readmission, for example, will almost always be considered a potentially avoidable complication if it falls within that time frame. And they come from inpatient, outpatient, or professional claims, not pharmaceutical claims. For chronic conditions, a lot of what we're talking about when we're talking about complications are exacerbations of the underlying condition that might require like an ED visit or a hospital visit. As far as the time frames go, they include procedures that occurred during an index procedure or during the stay if it's inpatient. They include readmissions, and they include other PAC-related services that occur during that entire post-discharge period. So as I mentioned, there are caveats or limitations of the analysis that we should just mention before we dive in. The analytic approach of the hierarchical model with the random intercepts and the covariates does attempt to account for all the potential factors that account for differences in the cost and complications between the BTE recognition and non-recognized providers, based on the data that we have available to use for those controls. That being said, there are unabsorbed factors that could potentially explain the results that we can account for, like provider or practice-specific characteristics, things we don't have in the data, staff size, approach. So as mentioned, just keep in mind that it's not a cause and effect analysis, but rather a correlation, but as you see, a statistically significant correlation. So I hope this slide is visible. So just some descriptive stats for each of the three conditions. So starting at the top, the N at the top under each is showing essentially the number of patients with each condition. So diabetes and hypertension, significantly higher volume than the coronary artery disease. The breakdown of the non-BTE to BTE providers is really similar for diabetes and hypertension at about 3/4 non-BTE and 1/4 BTE. In general, you can see that the PAC percent is higher for the non-BTE group. There's no real difference in the breakdown of female versus male, or the age groups between BTE and non-BTE recognized providers, and no substantial difference in the comorbidities or co-occurring chronic conditions between BTE and non-BTE providers. There is some difference in the breakdown of HMO, with a higher HMO population for the BTE recognized providers for diabetes and CAD, but the opposite is true for hypertension. But again, it's a variable that is one of the control variables. The average number of comorbidities is the same for the patients of the BTE and non-BTE providers. Specific to diabetes, there are some differences in the specific risk factors shown here. For example, 9% of patients of BTE recognized providers had a neurologic manifestation compared to 6% non-BTE providers. But again, these are all part of the control variables in the model. And some considered factors related specifically to hypertension and to CAD, again, all part of the model. So what do the results show us? So the top line here is the effect on costs. For diabetes, the patient episodes of BTE recognized physicians were 16% lower than those for non-recognized physicians. For hypertension, that difference was about 24%, and for CAD, about 11%. As far as the complications go, the patients of the BTE recognized physicians were 5% less likely to experience one or more PACs compared to the non-BTE physicians. For hypertension, they were 5% less likely. There were no real differences in that particular measure for the coronary artery disease. And you can see these results, other than CAD, for complications are all statistically significant, as indicated by the asterisks here. Just to give you an idea of what those PACs are and to quantify their impact, here we're showing the most significant complications for diabetes and the cost attributed to those complications for the recognized providers, that's the blue or the turquoise colored bar, and the unrecognized providers in the gray. And these are normalized on a cost per 100 episodes basis. So you can see in each case the turquoise bar is shorter than the gray, indicating a lower PAC cost rate for our BTE. The most significant complication here is the hospitalizations, that top bar. These, as I mentioned, are basically ED visits mostly, or sometimes inpatient hospitalizations that are related to treat the exacerbation of the underlying diabetes. The second most common complication is the outpatient treatment to treat similar exacerbations. The point being here that the non-BTE providers consistently have higher costs associated with PACs when compared to providers. A quick look at those PACs for hypertension, again the predominant one being the hospitalizations, again ED visits mostly, to treat the exacerbations of hypertension. But again, the lower PAC-related costs consistently for the BTE recognized providers. And for coronary artery disease, the same story. Lower complications related costs for the BTE recognized providers generally. A little different set of complications, including those hospitalizations, but also including things like shock and pneumonia. So in summary, that finding slide again, we found anywhere from an 11 to 25% lower average cost for the patients of recognized providers. And as you might have guessed, some of that difference is driven by the incidence of complications and the relatively high cost to treat those complications, right, the hospitalizations. And we also found that patients of the BTE recognized providers were about 5% less likely to incur a complication associated to their condition. Again, holding other control factors constant. This did not apply to the coronary artery disease recognition. And a reminder about the caveat again that this is a correlation, not necessarily a causation. So I wanted to just pause here and give you an opportunity to ask any questions about that study in particular before we moved on. I do see one question here from Michelle, so let me see if I can expand that. Did you look at whether the non-BTE practices had recognition for patient-centered medical home or NCQA clinical recognitions? We did not. That's not part of this particular analysis. Marcela, I don't know if we have any information kind of about the overlap with the PCMH and the NCQA. And let me see, Michelle, looks like you clarified your question a little. I should have said whether the PCMH NCQA recognitions were looked at for BTE or non-BTE practices.
So those would be included, not necessarily PCMH, but the NCQA recognitions. All NCQA clinical recognitions are included here as well, because we receive a file from them, and we do honor those recognitions as well. So those would be included in this study.
And so those that are recognized through the NCQA then are part of that recognized group.
Correct.
Okay. No other questions at this time? And again, I think at the end we'll have some time to just open up the lines if you want to pose your questions orally rather than through text. But we can move on at this point and I think hear from Bob Smith of the Colorado Business Group on Health.
All right. Thanks very much, Stacy. And you guys can hear me okay?
I can.
Okay. Great. Great. I usually forget to take it off mute, so thank you. Yeah, no, so thanks very much for that. I really appreciate that overview. This, to us at CBGH, was really a very important study, and we're extremely pleased to see the results for a couple of reasons. One, the diseases that you look at, diabetes and coronary artery disease, hypertension, these are significant contributors for all of the populations of CBGH members that we have looked at. So these diseases are directly and indirectly contributing significantly to costs. The second thing is that this is the first study that is relevant to our state, and I'll share with you a couple of other studies that have been done. But this is relevant to our state, it's our population, and in particular, it's our costs here in Colorado. The third reason is that it updates and quantifies some of these earlier opportunities that it's difficult to quantify the benefits of BTE recognition, and this study both looked at quality and cost, so I appreciate it for that reason. And it's consistent with earlier studies. So let me come back to, if I could, slide 21. And I want to look at slide 22 first. And when I say it's consistent with the earlier studies, let me just very, very briefly highlight this. The first and the earliest work in variation in healthcare was observed by John Wenberg, an epidemiologist and statistician back in the 70s, who observed that everything from hysterectomy rates to various kinds of surgeries and other procedures varied 300 to 500% within just one state across a couple of communities. And when he looked at why there was such wide variation in resource use and indeed in procedures, what he found was that 75%, actually it was a little more than that, of the differences were due to provider preference. Only about 22% of the difference in variation, we're talking 300 to 500% resource variation, was really due to patient need. Since that time, then the Institute of Medicine looked at the issues of overutilization, underutilization, misuse, and found that one of the major contributions is to the 35% waste that we have in healthcare, and many studies have estimated that it's higher than 35%, derived from underutilization, and that begins with diabetics not getting the care that they need, and I'll come back to that in a second. On the other hand, overutilization is a major issue, and not only did a 10-year study in the Mayo Clinic Proceedings that was published just a couple of years ago suggest that 40% of services either don't help or actually harm patients, but I recently saw Washington Health Alliance, which is the equivalent to CBGH up in Washington State. They looked at 50 of the Choose Wisely procedures and found exactly the same thing. About 42 or 43% of procedures the Choose Wisely procedures were overutilized and didn't help or actually harm patients. So when I first came to CBGH in 2010, we ran a Prometheus episode analysis on all the major payers in the state. I think virtually every payer in the state, Cigna, United. Well, we didn't get United. We had Cigna, Anthem, Aetna, and others, Rocky. And what we saw was that 25 to 50% of all spending on diabetes represented potentially avoidable complications or PACs. And we also saw wide variation. No one did any better than any others on any of these diseases. So variation is ubiquitous, as Dr. Winberg said, and that's why, if I go back to this slide 21, I think that clinically it is as relevant. Bridges to Excellence remains as relevant as it ever has been, because one, of the increase in diabetes and cardiac that we see, and the need to improve that, and two, because it utilizes outcomes-based measures, and we'll look at that. But it's truly a quality improvement model based around clinical outcomes. Additionally, and related to that, we think it's relevant financially because it literally proves that improving outcomes in patients, and it's the function, not the form, of the primary care practice that makes the difference. Improving quality reduces costs, and we know that by looking at these outcomes. And then and where the real opportunity, and I'll show you this in a slide or two, comes for the sponsors in Colorado that have used this, would be in expanding access to BTE physicians. And I'll come back and talk about that. Strategically, BTE aligns with private and governmental pay-for-performance programs. I think it aligns, and Marcella, I might ask you to address this in a little bit, both with, well, particularly with the CPC Plus model and some of the things that Medicare is doing. So let me jump down to then slide 23, and I'm actually going to ask Marcella to address this slide. These are the actual scores or the measures on which physician practices are scored. And so, in a sense, this is really the beating heart of the Bridges to Excellence program. And it's on these scores then that we gather, on these measures, that we gather patient information from clinical records. Used to be manually, now it's mostly electronically submitted. One of the things I like about this is it's payer indifferent. It captures all the payers, and again, it's based on outcomes. So Marcella, would you just explain this table a little bit on slide 23?
Yes, of course. So this is one of our programs, right? So looking at this particular table, we list all of the measures and then the total points based on what we feel is the most important, right? So as you could see, 20 is probably the highest on this particular table, being the hemoglobin A1C control. So all of these measures within any of our 8 programs are weighted based off of what should be clinically represented, right? And then the level of evidence and the source is included. So for all programs, we do always list a source. We want to make sure that all the measures are relevant currently within as far as medically, clinically relevant. But at the same time, we want to make sure that BTE also recognizes those providers that have gone above and beyond and provide excellent care. So while providers are participating in such programs as CMS, the clinical quality measures, and so on, while these measures do align with the majority of those, we also take those measures and maybe go a notch beyond, just to make sure that we are representing, or we are rather spotlighting those providers that are going above and beyond on a daily basis. to provide excellent care, making sure that patients are staying out of the ERs, making sure that we're keeping them out of the hospitals, right? And so by way of doing this as well, by participating in any one of our BTE programs, providers are also able to participate in the MIPS category, which is improvement activities, and we're very honored to be listed, within the MIPS MACRA arena, if you will. So by providers participating just in this one program, let's say, they will automatically get the weight activity comes in as a medium, and they would be able to participate and I guess satisfy that particular requirement and get those credits. But any one of these programs, when you look at it, it does include clinical, it includes processes, it includes improvement. So what happens is providers can submit their data and they will get their scores back. They will get a report back. Where can they improve? What can be done better? And then within 90 days, they can try again for a higher score. So it's always about us making sure, or BT making sure, that we are helping not only the providers succeed, but making sure that all of our programs improve the quality of care experienced by patients and reduce the financial and human burden of long-term complications.
Thank you very much, Marcella. And to your point, and I think this is significant, it is a recognition program, and I'll explain that in a little bit. But beyond that, it really can be and should be used as a quality improvement tool, and frequently is. Now, I was excited to have this study on Colorado because it's relevant, but because really the literature's been fairly sparse on what program, what are the impacts on dollars and costs of some of these programs. One of the earlier program studies that I had come across was this one that you see on slide 24 in Health Affairs, how medical groups can improve costs, reduce costs by improving quality. And this has kind of been at the heart of the philosophy of the Colorado Business Group on Health over the years. And that's why we've focused on quality improvement programs like this. This study actually was designed to look at the quality of care for patients specifically with diabetes, when various practice characteristics were taken into account. And what you'll see on the next page is that improving quality on diabetics did in fact improve, result in the documented savings about $51, and that's net savings of $51 PMPM, or roughly $600 per year. And there were, and I won't get into this, practice structure variables. So it was kind of an interesting study. Beyond that, the next study that I came across, and this was about the last, the only other study I was able to determine, was one that was done by Meredith Rosenthal at Harvard University, and it was done in conjunction with the Healthcare Improvements Institute that had actually helped develop the Bridges to Excellence program. They came up with Meredith Rosenthal came up with a savings of roughly $438 net per patient per year. So if I just take the average between those two estimates of savings for diabetic patients, it came up to about $494 a year. So as then what we've done at the Colorado Business Group on Health is when we look at the sponsors, we've said, okay, over the course of the years, for those people who sponsor, by which I mean they are willing to pay the Colorado Business Group on Health an administrative fee for managing this program, and it's fairly complex and cumbersome to manage. And then they pay $100 for diabetes recognitions, and they pay the physician $160. And what we do is then, so let's say we had 3 or 4 health plans and several employers, we aggregate those recognition dollars, and then we send that to the physicians. So this was for one of the health plans that was sponsoring, and you can see over a multi-year period the number of eligible patients, which means they would have triggered with one of those diseases in the prior year, or triggered with diabetes in the prior year. The administrative fees that were incurred, the physician rewards that were paid out, and then the total. And so you can see the number of diabetic patients, and then we multiplied that times 494, and it gives you the net savings. Now, what's evident on this page is that unless there's a really concerted effort to get people to see a BTE physician, the administrative fees are actually, it can be higher than you would want to see them be as a percentage of the savings. But the key to that is we've overall only gotten employers or health plans that have sponsored BTE to see roughly anywhere from 8 to 11% of their patients are seeing BTE physicians, and so that's part of the problem in realizing the savings. So for this particular plan, and we looked at this a couple of years ago, the annual savings at the 11% participation rate was only $150,000. But you could see if they had just gotten it up to 25% participation, they could have saved significantly more money. And again, those are net savings over any administrative costs. So we think that there's a substantial financial payment or financial reward for the sponsor in doing this, but more importantly, of course, patients get better care. So we're the authorized BTE administrator in the state of Colorado. The sponsors are a couple of health plans, and then several of our self-funded employers sponsor the plan. They contract with us and agree to pay the physicians, as I mentioned, $100 or $160. They pay us an administrative fee, and then we take the data files that are necessary to administer the program and consolidate the payments and the rewards, and then we actually deliver those rewards to the physicians. And so you can see what our responsibilities are on the bottom of that slide, and I won't read them for you. And so the importance, I think, of this study, and I'll just throw it open to questions then. The importance of this study is we wanted to show why we think that Bridges to Excellence continues to be a best-in-class tool, why it results in better outcomes for patients, and how it saves money for employers and sponsors by looking at really the right things, which are, did the patient get the kinds of services they should have gotten, and did they have the kinds of outcomes they should have had. So with that, we'll throw it open to questions, and I understand that any of the participants on the phone can unmute their phone by pressing *6, and if you want to ask a question, you can either type it into the questions and answers, or you can unmute your phone and ask us directly.
Yep, either way will work.
I'd also volunteer that anybody that wants to just email us, and you have our contact information on slide 30 here. If you want to email us any further questions, we'd be happy to answer them. We could do a rough back of the envelope estimate of what your savings would be, or what the program, if anybody on the phone is interested in doing this. Oh, and by the way, one thing I did not mention, I know there are a couple of folks on the phone from WellCare. We had seen, and I'm blanking on his name. I think it was Dr. Morale, who had come out and presented at a program that we had on Bridges Excellence here. I want to say it was 2 or 3 years ago, And he presented 10 years of results for Blue Cross Blue Shield of Texas that consistently showed savings. It was significantly higher than I had projected in this. As I recall, it was $750 to $1,000 per member per year. So I know that Blue Cross Blue Shield has been a very big supporter of the Bridges to Excellence program, and it's a key part of their quality improvement program in Texas. And those results, while I don't believe they were published anywhere, were significant. Questions?
And I should note that you can upload the presentation. You'll see a little download box
right.
where you can download that file.
Well, I want to conclude by thanking the folks on the phone and participating in today's webinar. Again, download the slides if you have any questions about anything that's on there, or you would like to talk about the Bridges to Excellence program. I'd be more than happy to talk about it. And then I do want to thank very much Marcella and Stacy, not only for coordinating the study, but for your time today in putting this program on. Thank you very, very much for doing this.
You're welcome.
All right.
All right.
Stacy, any concluding comments?
No, I think as you mentioned, we were showing our contact information here, so feel free to email any one of us if you have additional questions.
All right. Very good. Thank you all very much.